We are here today to talk about hospice care. You may or may not have experience about hospice care, but some of you may have experience with palliative care. Uh, Palliative care is nothing but a provision of good comprehensive pain and symptom management to patients who are facing serious or terminal illness. So, today in this video, we are focusing on hospice care and what is the length of the hospice care. Um, it is also a part of our palliative care. So, in USA, over like 1.5 million people receive hospice care in a span of an year. So, during the time period, Americans who have known they have some illness or their family members have some illness, they were being treated for and they wanted to move to a more secure phase of their illness. So, if you or your loved one have received news from their physician about their illness and they want to make a choice or decision to make through a more thoughtful palliative supportive model than a curative treatment, they prefer hospice care. So the hospice care mainly focuses on care but not on cure. So the objective of hospice care is to provide uh, the patient and their family members enough moral support to allow the process of dying to take place in a more comfortable setting as possible. This hospice care is also identified as a highly connected to their family as well because it gives a moral support to the patient and their family uh, to make a comfortable dying of the patient.
The term hospice can be traced back to medieval times when it referred to a place of shelter and rest for the weary or ill travelers on a long journey. The name was first applied to specialized care of dying patients by physician Dame Cecily Saunders, who began her work with the terminally ill in 1948 and eventually went on to create the first modern hospice, St. Christopher's Hospice, in residential London. Saunders introduced the idea of specialized care for the dying in the United States during a 1963 visit to Yale University. Her lecture was given to medical students, nurses, social workers, and chaplains about the concept of holistic hospice care. It included photos of the terminally ill, the patients, and their families, showing the dramatic differences before and after the symptoms were controlled by care. This lecture launched the following chain of events that developed into the hospice we know today. 1965, Florence Wald, the Dean of Yale School of Nursing, invited Saunders to become a visiting faculty member for the spring term. 1967, Dame Cecily Saunders created St. Christopher's Hospice in the UK. 1968, the Dean Wald took a sabbatical from Yale to work at St. Christopher's and learn all that she could about hospice. Florence Wald, along with two physicians in 1974, founded the Connecticut Hospice in Branford, Connecticut.
In my section, I'm going to talk about the length of stay in regards with the hospice care. Uh, First, actually, the idea of the hospice, even though it started in England, but the first hospice in the US started in 1974 at Bradford, Connecticut. And over the years, different laws and acts were enacted by the US federal governments to regulate the hospice in this country. Uh, um Hospice care for the people of life expectancy of 6 months or less. But if someone live longer than 6 months, they can still get hospice care. If the hospice medical director or other hospice doctor rectifies that they are terminally ill. But according to the view that length of stay in terms of hospice is a bit a complicated term, and it's not just a straightforward term as you calculate in the hospital. Before, as most of the patients were the cancer patient, it was straightforward to calculate the 6 months prognosis. But as the trajectories of the diseases have changed and most of the patients are living with the terminally ill diseases, their prognosis and their length of stay in the hospice has been changed, and because some patient may stay longer in the hospice and some patient may be discharged in the hospice a bit early. If we see some of the statistics in year 2015, 28.2% of hospice patients in the United States received 1 to 7 days of hospice care, and only 13.1% of patients received more than 6 months of hospice services. If we look at the Medicare, I mean, what hospice length of stay covered by the Medicare? Medicare covers the hospice expenses for the eligible patient, but hospice provider patient choose must be Medicare approved. Medicare covers all the services for any health problem that are part of your terminal illness and related condition, but patient must pay the deductible and coinsurance amounts.
The long tail theory was developed by Chris Anderson, and it proposes that greater value is found in the tail of the product distribution than its head, essentially stating that finding a way to offer niche services within the product distribution is a great way to generate value within one's operations. When considering the application of the long-tail theory on population and financial management within the healthcare setting, and specifically in relation to hospice care length of stay, we must consider what would be thought of as the head and tail of the distribution. It would appear that the head of this distribution would be the previously recommended hospice enrollment period of 53 to 105 days before death. In a rigorous study by Donald Taylor and his colleagues, they observed the aforementioned 53 to 105 days as the period that maximized Medicare savings when compared to expected non-hospice care. The tail of this distribution would be similar services for different enrollment periods, including the much shorter periods in a 2013 study by Amy Kelly and her colleagues. In the Kelly study, periods of 1 to 7, 8 to 14, 15 to 30 days were all studied, and all were found to provide greater Medicare savings than the recommended period of 53 to 105 days from the aforementioned Taylor study. So, what is driving these findings, and what are their implications? Driving the greater savings, according to the Kelly study, is the per diem cost of hospice care. If a person enters hospice care too early, the costs associated with it can reduce some of the financial benefit of the hospice care. The implications of this study, therefore, highlight the need for sound population management strategies that allow healthcare organizations to accurately identify the needs of patients during their end-of-life care. The population management system and the strategies therein will be able to identify when it is in the best interest of the patient for quality of care and end-of-life quality of life, and the healthcare organization at large to discuss more palliative care options.
Why I'd want to work with people who were dying. It must be very depressing, it must be very sad. I think you get to see the power of the human spirit when you work in palliative care.
I just feel very privileged.
What it is it's very real.
You know, the people who are dying, they give me more energy. They teach me so many lessons.
It's emotions, actually, that's what it is.
Over the last 30 years, there have been significant changes to the types of patients using the hospice benefit and the costs associated with care. In 1990, 16% of Medicare hospice recipients had a non-cancer diagnosis. In 2010, that number increased to 69%. And in 2016, it was over 80%. Why does the primary diagnosis matter? The primary diagnosis can have a significant impact on the location where a patient receives services and also on the length of stay. Treatment for cancer is usually chemotherapy and or radiation. Once stopped, the disease can often progress rapidly. These results are reflected in the data where the average length of stay for cancer is 53 days, but increases nearly 3 times for neurological conditions where the average length of stay is 147 days. Not only does diagnosis have an impact on length of stay, but the location a patient is receiving services seems to play a role as well. The average length of stay for patients at home is 89 days, 105 days for those in a nursing home, and 152 days for patients living in an assisted living facility. Studies found that hospice patients living in assisted living facilities were older and more likely to have dementia as their terminal diagnosis than those in other locations. When comparing patients with the same diagnosis, patients in assisted living facilities had much longer stays. This raises questions about who is targeted for hospice, specifically those in assisted living facilities and nursing homes, and if some enrollees actually meet the 6-month life expectancy criteria.
Today, I want to talk to you about Hospice General Inpatient Care, or GIP. When it comes to length of stay, Medicare policy does not specify the number of days GIP is allowed, although it is intended to be short-term. A national study of nearly 3,000 GIP providers indicated that 1/3 of all GIP stays lasted longer than 5 days. More than 11% of all GIP stays were 10 days or more, and 2% lasted longer than 3 weeks. Our breakdown of stays by facility type showed that inpatient hospice had an average length of stay of 15.2 days. Inpatient hospital stays lasted an average of 9.7 days, and stays in skilled nursing facilities averaged 23.2 days.
Another trend is the number of for-profit facilities enrolling hospice patients, specifically assisted living facilities and nursing homes. In 2010, only 30% of hospice facilities were for-profit. In 2015, that number increased to 63%. When comparing patients with the same diagnosis in different settings, patients living in assisted living facilities had much longer lengths of stay. This raises questions about who is being targeted for hospice services, those in assisted living facilities and nursing homes, and if all patients are actually meeting the 6-month life expectancy criteria. The hospice benefit was put into place to provide quality, compassionate, end-of-life care for terminally ill patients. In addition to providing care, Medicare would save money by avoiding frequent hospitalizations and high-cost end-of-life procedures. Prior to 2015, Medicare paid a flat daily rate for in-home routine hospice care. The longer a patient was in care, the more profitable the stay became. Reviewing trends in services, the Center for Medicare and Medicaid Services reformed the way it reimbursed for services. The single daily rate was replaced by a tiered payment model, reimbursing higher rates for the first 60 days, a lower rate for days 61 plus, and additional service intensity add-ons for the last 7 days of life.
In conclusion, hospice care can be conducted in a few different ways. 98% of hospice care is performed in someone's home. 0.5% of hospice care occurs at a hospital, while 1.3% is in a hospice facility. The actual length of stay in hospice care was 53 days for a disease that progresses quickly, like cancer, and 147 days for neurological conditions that may have little effect on life expectancy. Hospice care is also taking a big toll on Medicare costs. In 2015, Medicare spent $15.9 billion on hospice care. If we can effectively implement the long-tail theory, then these financial burdens of end-of-life care can be decreased.